Welcome to the Orthodontics in Conference podcast, where Farouk brings you the summary of key lectures from orthodontic conferences around the world, with your host, Farouk Ahmed.
Welcome to this episode of Orthodontics in Conference. I'm delighted today to bring you the first day of the British Orthodontic Conference 2021. The first day, we have a series of 5 lectures to cover. We're going to go through a range of research topics. We're going to look at the Chapman Prize, where we look at full-time versus part-time functional appliance therapy. We're going to look at retention with Simon Littlewood's lecture, which was amazing, and Sarah Good describing her experiences and practice when it comes to managing our younger patients and traumatic episodes. We'll conclude with a lecture looking at lingual appliances from diagnosis to retention. And to recap, this podcast is an opinion piece from myself and may not be 100% accurate or representative of the lecturer or speaker, although we try our very best to make sure it is. The podcast is not endorsed by the Institute or the speaker and is my independent work. And I'll be catching up with you guys at the end to give you my reflections of day 1. This podcast is covering the University Teachers Group, which are research presentations by trainees or residents during their training period. So I'm going to be covering 8 of their presentations, a variety of topics that they looked at, including looking at bonding strengths, looking at reporting in randomised controlled trials. There was a real focus on qualitative analysis, decision-making with patients, also why we make the decisions to extract in orthodontics. Looking at the training program effects of going from face-to-face to virtual during the pandemic, and also gender barriers when it comes to careers in orthodontics. The first title was a randomized controlled trial to compare preparations of molars for orthodontic bonding with and without a tungsten carbide burr. This was by Misha Verdi, and it was a very well-conducted trial, essentially looking at preparation using a burr versus no preparation and bonding failure rates. It was a very well-conducted split-mouth study, and it was a 12-month follow-up trial. What were the results of this study? Well, she found that without using a burr, the failure rate was around 12%. However, when a burr was used to prepare the molar tooth, that dropped down to around 7.9%. So there's a 5% reduction. Now, looking at the statistics, that wasn't statistically significant, but Misha argued that it was a clinically significant difference. When it comes to her own clinical preparation for patients now, she will use a tungsten carbide burr to prepare the molar tooth surface. She broke down the study further and showed that this was more prevalent in the maxilla, where it made a bigger difference, when there was a 10% difference between prepared surfaces and non-prepared surfaces. Interestingly, they also explored gender and found there was no difference between males and females. The second lecture was entitled Advertisement in Orthodontic Journals, Are They Evidence-Based? This was by Usman Hamid, who I know professionally as he was one of the first people I trained when I became a consultant. I'm glad I've not put him off the profession. So Usman presented his cross-sectional study. He used a validated questionnaire and essentially assessed the adverts that are presented in our journals. He looked at, is there evidence to support their claims when they made a point to look at clinical superiority? And he found, as we may suspect, the majority do not present any evidence. Only 35% had evidence supporting their claims, the majority do not, yet they still appear in our journals. He broke it down further. When he looked at what that evidence was in these adverts, actually the majority was anecdotal. They did not provide any reasonable or high-quality evidence when it came down to their claims. Usman's conclusion was the majority of adverts who claim clinical superiority do not present the evidence, and we have to bear that in mind when we read our adverts, even if they are within our own clinical journals. The next lecture was by Georgina Kane, and this was looking at the correct labelling of orthodontic randomised controlled trials. Here she assessed a number of RCTs using a systematic approach to see how they describe the randomization process accurately. And this comes back down to the reporting notion of our literature. When we write something, does it mean what it says? She looked at the randomization process, if it was described, but also allocation concealment. And she looked at a large body of data, and credit to her for doing so. And what she found is that 64% of our RCTs in orthodontics do describe this data. However, we have 30% that are unclear and 6% where they don't describe this information at all. And the outcome from this research was that 1 in 3 trials are inadequately labelled. Next time I'm looking now at a journal, I will be looking more attention at this allocation and randomization description before I then start taking that information on board. The next presentation was by Daniel Stonehouse Smith, and he was looking at really the statistical side of our research, looking at the effect size assumptions in orthodontic studies. So this is an interesting topic, well, at least he made it out to be, and that was looking at sample size in our studies. And simply putting it, are we carrying out the calculation correctly for our randomized controlled trials? The backdrop to this is that in medicine there is understanding that when it comes to sample sizes, there's a bit of an exaggeration when it comes to the effect size. Essentially, we think things are going to happen more, but actually in the trial it ends up being far less. And interpreting this when it comes to methodologies essentially means we may go for a smaller sample than what we actually need to look at that particular study. So he carried out a systematic review looking at these randomized controlled trials. Again, a very large body of work, and credit to Daniel for doing so. And he found that actually in a majority of cases, RCTs don't describe this information clearly. But when he did manage to distill down to that information, what he found is that there was a significant difference between what we used for our sample size, for the effect size, and what was actually observed in the treatment effects. So we aren't really looking at our studies in the best way possible. And Daniel's recommendation was to avoid using this a priori approach, an assumption of what we think is relevant for an effect size, and actually look closer at the literature to derive that calculation. The next lecture was looking at a qualitative evaluation of attitudes towards extractions amongst primary care orthodontics. This one goes back to that old question, do we extract, do we not extract? What I liked about this is that we looked at it from a qualitative side. So what are the reasons as to why we make that decision, as opposed to just looking at the clinical outputs, for example? So the methodology was a qualitative analysis. A one-to-one interview took place with a topic guide, and these were the themes that came out of this piece of research. There are patient-related factors as to whether we decide to extract or we don't extract. And the examples that were given, if a patient has poor oral hygiene, we're more likely to extract. If a patient has a third molar present, we are more likely to extract to disimpact that third molar. And very interestingly, when it comes to adults versus children, in adults we're more likely to avoid extractions due to perceived difficulties in space closure. The next was operator factors. So what was observed through longer-term clinical practice, we tend to go for more extractions the further we go through our careers. And I thought that was interesting. The presenter was very clear to describe there is a journey where we may go up and down in our extraction approach, but it's interesting what happens towards the middle to latter stages. The setting is important, and what she found was that in poorer socioeconomic areas, there tend to be greater extractions, perhaps feeding back to this poor oral hygiene and socioeconomic deprivation. Interestingly, private versus National Health Service didn't seem to make much of a difference. Mechanical approaches. The use of headgear being far less prevalent than it historically was means there seems to be more extractions taking place as a result. What was interesting when the discussion took place of interproximal reduction is that the use in adults was common, however in adolescents there was apprehension in using this approach. And also self-directed learning has been the last theme as to why we decide to extract. Conversations with our colleagues attending conferences does influence and steer our decision-making. The next lecture was looking at shared decision-making in adult orthodontic patients. This was a cross-sectional study carried out by Farnaz Motomendi. And Farnaz is a senior trainee who works with me and has the misfortune of having that experience on a regular basis. So Farnaz's study was looking at adults' preferences when it comes to their involvement in healthcare decision-making versus their perceived role in healthcare decision-making. This was a cross-sectional study that she carried out using a validated questionnaire. And her results were that the perception of their roles of patients is that they consider themselves to be passive, and they would prefer to be more active, generally speaking. She broke down the data, and it was interesting to see the difference between the genders. Males preferred actually to have more of a passive role in this decision-making process. Females preferred the opposite. They wanted to be more active in this decision-making process of their care. Now, she showed that there was only 45% correlation between the perceived and preferred roles. So we're only getting it right less than half the time. But actually 55% of patients, what they perceived from decision making and what they actually wanted were not matched together. But this varied, and it wasn't a one blanket fits all. So what Farnas concluded with is that patients do have this variation in where they want to be in this shared decision process about their healthcare. Genders prefer to be more active, males generally tend to prefer to be more passive. However, when it comes to shared decision making, when patients are involved, they generally tend to have better patient-related outcomes at the end of treatment. So part of what we should do at the stage of having consultations is also tell them the advantage of being involved in this decision-making process, but also listen to what they wish to do when it comes to their own involvement. The next lecture was by Olivia Johnson King, and she was looking at postgraduate students' perception of face-to-face and distance learning in education. And this is a common theme within orthodontics and general education about how things went from being face-to-face to being virtual due to the pandemic. She looked at trainees from her own educational institute, and she carried out a formal approach to the qualitative analysis. She had training, also transcription by professional companies. So it sounded really robust from my perspective. What were the conclusions? Well, the themes that seemed to come out were the social support network, how that is missing from distance learning. Technology was a key theme. If the quality of the internet wasn't good, this related directly to the quality of the learning and also the cost implication for trainees. Other notions that came out. Well, when it came to looking at the effectiveness of teaching and learning, this was interesting, is that when it came to theory, there was almost a preference towards having distance learning to absorb the information. When it came to practical learning, as we would expect, students found that challenging in the virtual environment. So the conclusion from Olivia's study is that face-to-face has advantages when it comes to social and peer learning and also practical elements of learning. However, the virtual platform does have advantages. It's better when it comes to theoretical learning. It has accessibility to it, which can be challenging when it comes to face-to-face. And actually, it's convenient when it comes to trainees' education. The final in the series of trainees' lectures was this one by Jennifer Jobson, a thought-provoking one investigating the barriers and facilitators to an orthodontic career, and if gender has a difference. Jennifer asked some really probing questions, and ones where we have to be honest as a profession. She spoke about how the majority of dentists are now females, at least within the UK. And there is this occupational feminization, where there are greater women coming into the workplace and occupying more roles. Her study was a qualitative analysis again, using purposive sampling and a focus group to carry it out. And her results were the following. When it comes to motivations for a career in orthodontics, the reason why we go into it is usually due to the longevity and the financial remuneration. What helps us along that pathway? Usually our mentors are key, especially when it comes to higher training and support from our family networks. Now, what this study really boiled down to were the barriers in place. So there's barriers related to inflexibility in training. Trainees found it challenging if they wanted to buy a house or start a family or have children, and also to balance the idea of having training. Finances were a big factor to this process, and also fatigue through the training process. Now, when it came down to the gender differences, this was interesting. When it came to females, they found it difficult to balance work with children. They also felt guilty when they were at work and not being able to fulfill and do it all, both their family duties or their self-perceived duties and also their job. Contrasting to men, when men were asked about what their barriers are, they generally felt balanced with work and were able to explore other opportunities outside of work. They found it relatively easy to start a family, felt well supported in that process, and felt the careers for them were based upon them being in the right place at the right time and being opportunistic. What the conclusions were from Jennifer's study? Well, there are different pressure points for different people and different genders in their careers. Males and females do have different career experiences. I think this is a key and very honest topic to have approached, and I'm glad Jennifer has raised this topic. The The next lecture has received a number of prizes, including the Chapman Prize with the British Orthodontic Society, and this was Pratik Sharma and Padhraig Fleming's lecture looking at the prescription of full or part-time twin block wear, a randomised control trial, and qualitative analysis. So these were based on 2 papers published in the AJODO in 2019, looking at the RCT, but also looking at qualitative assessment. Now, the aims of the study was to look at full-time wear, 22 hours, versus part-time wear at 12 hours. It was a randomised control trial with a relative standard design of twin block. They incorporated an objective measure of patient wear using a thermon detector. Now, the results were part-time versus full-time. Well, there was no difference when it came to the overjet changes, which were approximately 7 millimeters. No difference in skeletal changes using patch analysis and changes at Pagonian, and no changes in A and B. Skeletally, dentally, no difference between part-time and full-time wear. Now, the interesting point of this RCT was looking at the compliance. They reported on what the patients thought they'd worn the appliance and also the actual wear from the thermon detector. And this was interesting. So the part-time guys were reporting they wore it for 11 hours, actually only wore it for 8 hours. Full-time were reporting 20 hours of wear, but actually getting 12 hours of wear. So actually in both groups, patients were actually only wearing the appliances part-time. The conclusions from the randomized controlled trial was that there's no difference in skeletal or dental changes if a patient wears a functional appliance part-time or full-time. Part-time, it ranges between 8 and 13 hours to get these dental and skeletal changes. Patients over-report what they've actually worn the appliance for, which I think is interesting in itself. And then it came to the qualitative analysis. So this was what Padhraig Fleming then spoke about. So this is where they had one-to-one interviews with patients participating in this study. They looked at part-time and full-time patients, as you'd expect. Now, the key themes that they discovered from this piece of research was the self-motivation of patients, if they received positive reinforcement from the clinician or the parents themselves. Social influence of wearing a functional appliance, the teasing that takes place initially. And also he spoke about the pragmatic issues of a functional appliance. It can be forgetfulness on behalf of the patient, and also the effect of speech when it came to schooling. Now then, Padhraig then broke down how he now uses this piece of research. So his timeline. Initially, the patients wear the appliance 4 weeks and it's nighttime only. And this allows them to get on top of the social impairment side of things, get used to it from speech, and also the forgetfulness is then worked on. He sees the patient at this stage. Now, after 4 weeks, he then works on going towards full-time wear for the patients. Now, what was interesting was to see the contrasting opinion of Pratik Sharma, the other person involved in managing this study, where he goes for part-time wear for all of his patients throughout the whole duration of treatment. And I think this was really insightful, how clinicians, even those academics involved in the study themselves, can take the findings from a study and apply them to clinical practice differently. What Padhraig also spoke about was managing failures, how we want to minimize this as much as possible. And if that means we are then going to part-time wear throughout the entirety of the treatment, maybe just nighttime wear, at least we can still get the skeletal and dental changes we desire. He spoke about design considerations, minimizing visible components to avoid those social issues he found from his study. Also keeping the appliance simple to limit breakages, avoiding labial bows in the upper arch, but also limiting vertical opening so it's not uncomfortable for patients. And I thought this was a great presentation of a well-deserved piece of research looking at a practical piece of clinical appliance that we use on a regular basis and looking more into the depths of how it works and what we can do to make things easier for patients. The next lecture is entitled Retention, Science, Clinical Tips and Comedy Disaster. This lecture was delivered by Simon Littlewood, who's been a guest here on the podcast previously, and we've also covered a number of his lectures, so it was great to see Simon back on the stage. Simon described bonded retainers. He mentioned how some people see them as a panacea, however that may not be true. He described the failure rates associated with bonded retainers. This was a paper by Kokera, and this was in 2021, anywhere between 12 and 50%. Usually it's failures of the wire, but also adhesive sides of the bonding as well. There are other problems associated with a bonded retainer, and that is the unwanted tooth movement that takes place. This is different to relapse happening. This really relates to the wire itself undergoing some structural change and imparting a force on the tooth, going in a different direction. Simon first reported this in a case report going back to 2011. And essentially what's been found from a recent systematic review is that around about 1 in 100 cases, utilizing twist flex as their material for bonded retainer, show this unwanted movement. The explanation is varied and we don't have an answer definitively, but it could be that the twist flex unravels or there's occlusal forces causing distortion. So what's the other options out there? And that's what Simon explored in this lecture. Well, there's the option of having nickel titanium made bonded retainers using CAD/CAM design, and one of the popular names is Memotane. It has the shape memory properties of nickel titanium and is precision made as well. And the claim is it's ideal for the upper arch. The patient has a scan done, both upper and lower, or impressions with an occlusal record, and the technician then designs the retainer according to it. It's not cheap. It comes in at £95. The other option for material use is that of OrthoFlex Tech. Now this is stainless steel, but it's essentially a very floppy version of a wire. It doesn't impart any direct forces to the tooth themselves and therefore can't result in any tooth movement occurring. So there was a study which looked at these two which Simon was involved with, that of Memotane versus OrthoFlex Tech. And the aims were simply to see what the survival was like between these two, also looking at dental movements as well. Now, it was a robust methodology that Simon used. It was an RCT, it was multi-center in its nature, and no removable retainers were used. They just wanted to see what happens with the bonded retainers. Now, Simon reports that actually the trial had to be stopped after 6 months. The failure rates with Memotane had gone to 50%. So there was a safety issue with continuing the study, and this was 50% in the upper arch. The lower arch had failures of 35%. But what he also noticed in this study is that spaces sometimes opened up when it came to using the Memotane retainer. It looked as though there was a failure between the composite itself and the wire. And in doing so, the wire was now sliding in between the composite and spaces opening up. When it came to FlexTech, they had a failure rate of around 31%. And when Simon looked at the overall stability of the dentition, there was no significant difference. But Simon also stated the trial was stopped early. They hadn't recruited to the initial power they had planned for. When it came to patient satisfaction, they were all happy with the types of retainers that they had, either whether it was the FlexTech or whether it was the Memotane retainer. So what did Simon take away from this research? Well, he mentioned that problems do occur. And he looked at the survival rate, and actually the problems tend to occur in the first month. Now this changed Simon's clinical practice. He usually reviewed his patients in retention at 3 months, but now he's brought that forward to 1 month, because if they have a problem, it's usually isolated then. He also questioned whether or not nickel titanium is the ideal wire. He moved on to describing removable retainers. He quoted the famous paper now by Dalia Al-Moghrabi from 2018 looking at fixed versus removable retainers. And what he took home from that study was that after 2 years, it doesn't make a difference, fixed retainer or removable. However, at 4 years further down the line, it does make a difference. We know compliance from vacuum form retainers from that study showed that only a third of patients were actually wearing their retainers at that stage. And then there was a clinical difference between them. Interestingly, those third of patients who did wear the vacuum form retainers had no reasonable difference with respect to their stability and relapse compared to the fixed retainers. Then Simon spoke about the qualitative side of it, and I think this is a real theme of the British Orthodontic Conference, and it's great to see us looking more towards this to find more answers about orthodontics. Dalia Al-Moghrabi again reported on this, but this time in 2019. And what Simon has done is distill this down into 6 tips for patients when it comes to removable retainers, looking at this qualitative study. So he described the first one of misplaced retainers. His solution to this was to provide a spare retainer set at the initial outset, so patients always have that to go back to. He described the ease of replacing retainers. Patients need to know where to go, how to go, and what it will cost. He also spoke about introducing the fear of relapse, which I think in itself could be a parody. but the idea that if patients see relapse happening on other patients, they're less likely to not wear their retainers. He described the psychology of habits, associating a new habit with an established habit. For example, if the retainer is kept near our toothbrush and we brush our teeth, we will begin to associate the two together and a new habit is formed. He described of having a reminder when patients travel, the common thing we hear in clinic, that patients have forgotten their retainers when they've gone on holiday, or to put a reminder on their passport so therefore they remember to take their retainer. And finally, to remind them that nighttime wear is what they need to commit to. They are pajamas for their teeth and for them to commit to wearing it at nighttime only. An enjoyable lecture as always from Simon Littlewood, and great to see him doing some more research on this topic and finding more answers out in relation to retention. This lecture is entitled Things I Have Learned from Hanging Around with Kids, and this was a lecture delivered by Sarah Good at the British Orthodontic Conference. Sarah's lecture was based around her experiences managing trauma, hypodontia, and molar incisor hypomineralization. She starts off with a question really for the audience and described a difference in cultural practice when it comes to expansion in our younger patients. In the UK, we generally tend to only expand when there's a reasonable crossbite or functional displacement, but she's had patients internationally seen by herself, and in other countries, specifically the US, there can be a phase 1 expansion approach, and she described how the research is out on this one. And actually, there's a cultural clinical practice that takes place depending on where we are. And she left that question unanswered. And I think that's really reflective of where we are in a speciality. She then went on to speak about deciduous trauma, patients who had dilacerations to the upper central incisors. She highlighted and signposted the guidelines from the Royal College of Surgeons of England, which have some really clear instructions about how to manage this situation. She spoke about exposing and bonding these impacted permanent incisors and aligning them, either through removable appliances and then fixed appliances. She also mentioned her top tip. When this scenario occurs, there is a likelihood that the canines may also impact later on, so to pre-warn patients of further potential orthodontics and surgery. She spoke about patients who have avulsed teeth of their permanent incisors and of younger patients. She spoke about one of hopeless prognosis. And then she signposted the Dental Trauma Guidelines, which is an online resource which has up-to-date information about patient trauma management. She spoke about reimplanting teeth even if they have a potential poor prognosis. And we expect ankylosis, but at least it provides that tooth replacement for the patient immediately. And then thinking long-term wise of potentially decoronating this tooth when it shows signs of ankylosis to maintain the bone. Having a temporary prosthesis as the patient grows older, then looking towards having an implant. She spoke about molar incisor hypermineralization, and I think this is an interesting one. We do get patients sent to us from different specialities and general practitioners to make the decision on those molars. She spoke about the extraction guidelines, again from the Royal College of Surgeons, looking at extraction of first permanent molars. And what she said is that in her practice, she separates the two. Decisions for orthodontic treatment, which she makes a plan for, and separately she discusses the molar incisor hypermineralization. What's the prognosis of those molars? And she said it should be a team approach to make the final decision on those molars, if they're kept or removed as part of the treatment. Sarah spoke of a hypodontia patient who was also dentally anxious. Now here I really saw that Sarah is the clinician who listens to her patients. The patient's concern were gaps around their teeth. So rather than jumping in with fixed appliances, opening space and so on and so forth, she started off by adding some build-ups to the patient's anterior teeth, managing their immediate concerns. She then spoke about talking to these patients, how they have a feeling that their condition has been imposed upon them of dental abnormalities. And one of the ways she's seen patients express this is by not wanting to have more appliances than are absolutely necessary. For example, just having upper arch appliances. And I think that was really interesting and shows how in tune Sarah is with her patients. And I think it's an interesting idea to put forward to patients. There's an option for minimal intervention, option for ideal intervention, and then letting the patients have autonomy over what they haven't had so far, the hypodontia or the impacted teeth. Finally, Sarah concluded by describing an impacted canine case, how this one patient had severely resorbed lateral incisors. But rather than taking out those lateral incisors, having aesthetic compromise for a period, what Sarah did was to expose the canines, leaving the lateral incisors in situ, vertically aligning those canines, and only then having the lateral incisors then removed. Canines are then brought into place and built up at the same time. And that really is a way to keep the patient on board and not give them any aesthetic compromise. And again, for a condition which has essentially been imposed upon them. I enjoyed listening to Sarah's lecture. She gave a real-world scenario of these patients, but also how we can tweak the experience for these younger patients so they don't feel disadvantaged as a consequence. This lecture is entitled From Diagnosis to Retention. Is it clinically that easy? This was a lecture delivered by Esfandiar Modjahedpour. So Esfandiar started off by showing an excellently treated case and asked us to describe what the initial malocclusion was. I was a loss in the audience, but it was an impacted canine case, one that was exquisitely well treated using lingual appliances. And Esfandiar's talk was essentially based around his 20 years of experience going through different components of the clinical management. He was based very heavily on lingual appliances. He started off talking about diagnosis, looking at OPGs. He mentioned we can look up to 40 OPGs per day. But we need to spend the time to analyze them and refer when pathology is present. We could have once-in-a-lifetime occurrences of odontomas, for example, but we should be vigilant in looking out for them. He then went on to speak about the setups that we see and how setups have changed over his career. Now we're looking at end-goal setups for our clinical cases, whether it's aligners or customized lingual or label appliances. We described we need to find an eye to tune in to look for the key details. He described the golden proportions, looking at the mesodistal width of the central and lateral incisors, looking at the heights of the teeth, the gingival zenith, and actually we should be making these decisions from the outset of our patients. He spoke about different treatment strategies. He described the treatment sequence for patients. We can sometimes get that ideal patient, that everything goes swimmingly, we get to finishing and detailing, and actually we finish well within the times we've looked at. But it's the more challenging patients where we can take longer. He described that finishing can become a real problem if it extends time excessively. And he described we need to learn these processes according to our appliances, labial, lingual, or aligners. He gave an example of a lingual transfer case that needed some finishing and detailing. The lower centerlines weren't correct. And what he did to allow for this is to upright the lower incisors. That required a prescription to be supplied of 13 degrees, in this case, to allow the tip correction to occur. Now, he mentioned it may well have been simple and a solution to move on to label brackets, but he imparted that the professionality in using our appliance is that we also understand the finishing and detailing stages of the appliances we're using, lingual or aligners. So he wrote this as a prescription for his lingual case and had a wire customized to it. He spoke about extraction processes, specifically for lower incisor, how we have to be mindful when we extract the lower incisor, we do get a residual overjet. So in this case that he showed, he combined it with a Herbst appliance to allow the AP correction to occur and not to have a residual overjet. He then went on to an anterior open bite case for his treatment strategies. Now this particular case had an extraction of a lower incisor, but I was really interested in his intrusion mechanics. For this, he used temporary anchorage devices. Now he positioned them between the upper first and second molar on the palatal aspect. Now the way he achieved the intrusion was by bonding a sectional piece of wire on the occlusal aspect of the first and second permanent molar using some resin-modified GIC or blue glue. Now he then attached power chain from the TAD in between the 6 and the 7 through to this arch wire. This allowed him to get predictable intrusion of both of those teeth, and it also allowed him to intrude the posterior segments and allow a rotation of the occlusal plane. I thought it was a really simple application to achieve posterior intrusion, and I really liked it. He finally concluded by describing retention. He really went through the whole process from beginning to end. Now, retention, he spoke about a recent publication, which has come out in 2021, just a week or so before the conference, by Carnoob. And this was a study looking at twist flex bonded retainers and changes that take place subsequently. In this paper, which is a pilot study, they showed anywhere between 2 and 5 degrees of changes can take place. He described a theory as to why this happens with twist flex, and it's because the intercanal width wants to reduce. In doing so, it can induce a twisting effect on the actual bonded retainer itself. He also spoke about 6-strand twist flex being the best performance material currently available. I enjoyed listening to Esfandiar's talk. He gave a very clinicians-based approach to how he clinically practices and the things which are pertinent to him to achieve good clinical outcomes in practice. And that brings us to the end of the first day of the British Orthodontic Conference 2021. It was an enjoyable day, and I must say one of my favourite sessions from any conference is the presentation from the trainees or residents on their research. I think it's always an insightful session, and it shows us what thoughts are taking place within our field and also lets us see young people really committing to our profession. My conclusions from the first day, well, functional appliances featured quite heavily with Pratik Sharma and Padhraig Fleming. The idea that part-time is as successful as full-time, and actually to reduce our failures, potentially part-time works better. With retention at Simon Littlewood's study, we still don't have an ideal material. We have more products available, but we still haven't found that panacea, and we're still working towards it. What we do know is that patients are unlikely to wear their removable retainer after 4 years. When it comes to bonding my molar tubes, using a carbide tungsten burr is a way to reduce my bonded failure rates. Looking at shared decision making, which featured quite highly with the qualitative studies that were presented today. And that's where we involve both adults and children in helping make the decisions for their treatment. It increases the outcomes to their treatment as being positive, but also not everybody wants this. We need to ask how involved do they want to be in their decision-making process. Finally, when it comes to looking at our setups for our customized appliances, we need to assess the aesthetics in those setups, not only at the beginning of treatment, but also in our finishing, and have a plan how to finish each case well. Hope you guys have enjoyed this episode. Please stay tuned and look forward to day 2 of the British Orthodontic Conference.